I do think clinicians need to really, as you said, do a really good assessment and then go and, fight for their patient or their corner and say they really, really need this for these are the reasons, and I have the evidence and I know what I'm doing is right. So
yeah, it sat with me very uncomfortably. Every day that I used to go and visit, I'd think, but this is not what he wants. I can see it's not what he wants. And you could see in his eyes, he'd look at me and he said, I want to go home and die in my mum's arms.
Oh. I'm delighted to have you. It's an honour to have Dr Melanie Stephens sitting across the table from me, because I've heard so much about you in the past, read a lot of the stuff that you've done, and just want to welcome you to Seating Matters.
Oh, thank you for inviting me. Honestly, I'm really humbled to be here, and thank you.
So some of the things you've done that I've read that have been interesting to me at least has been that you've developed a care home placement programme where you put multidisciplinary teams into care homes. Can you tell me a little bit, just start there with that, tell me a little bit about that and why that's important to you?
Yeah, so quite a few years ago, I went to a place called Nijmegen, and in Nijmegen, in Holland in particular, they run patient recovery hotels. So they're almost like an intermediate care place, but it's where people go from hospital, where they need to have rehabilitation, or if they're not well at home and but they don't need hospital, they can go there. And the recovery hotel is run primarily by students in interprofessional teams. So when I saw that, I thought, well, this is visionary. I need to take this back to Greater Manchester. So I wrote a business case, spoke to everybody and the dog, really, even the milkman got to hear about this recovery hotel, and wanted to build something in Greater Manchester. And really at the time there wasn't the appetite. And I met this amazing woman called Carol LeBlanc, who is she was a director of nursing and then was a project manager nurse. And she said, well, we've got some monies, we can expand placements. Can you think about where else you could test and have a proof of concept? So we both agreed that care homes would be a great place because, one, we don't use care homes as placements as efficiently as we should. There's 34,000 nurses, OTs, physios working in care homes. So we'd try the concept there. So over the course of 3 years, we conducted 2 feasibility studies with 5 care homes across Greater Manchester and put students in there from across the 4 universities, from nursing, physio, OT, podiatry, prosthetics and orthotics, sports rehab. And we got the students to work in what we call them really action learning sets. And they worked with 2 residents, and the residents presented their goals, so they were person-centred. So this wasn't what the students wanted to do to the resident. These were the goals the residents wanted to achieve. So this could be something like, I wanted to put a concert on with my brother. I want to be able to transfer better. I want to go to a football match. You name it, the residents chose the goal. And then the students worked together to help that resident achieve the goal. But what the students didn't realise is by working on the goal, they had to do their normal assessments. So the OT student might do their assessment and show the other students how they did that. The physios did theirs, showed each other how they did that. The nurses. So they got to learn from, with and about each other, but also got to know these 2 residents, their conditions, their complex comorbidities. They got to learn about the seating, the mattresses, the sleep regimes, and they helped the resident achieve the goal.
And this was like a trial or a research project, was it?
It was, and now we've got some money to actually mobilise that knowledge and get more care homes having students from different professions.
So did that set, this is what I like about what you do, is you do research, but then you implement it into the real life. Yeah. Is that right? So is this now going to be rolled out, as you say, maybe to other facilities?
It is, yeah.
You have now evidence base for this?
We have, yeah. So we're doing some training for other care home managers to facilitate interprofessional placements. I've also been contacted by NHS London, so they want to do it, and some other universities in the south who've said, can we come and get some training? So for me, it's really important that we think differently about students' placements, that we can't work in, I call it splendid isolation anymore. We need to work as a team, because if we're going to offer true person-centred care.
Tell me a wee bit about the work that you've done. Apart from that, have you other research that you've done for interprofessional working?
Yeah, so it all stemmed from when I was doing a PhD by published works. I'm always interested in how can we make learning fun, but how can it then students, it becomes deeper learning, not surface learning that they don't remember, but how can they remember it so that it impacts them and impacts practice and the person that they're caring for. So I was involved in lots of what we call enrichment activities, so international placements, interprofessional education, wound simulation. So I researched all of these kinds of enrichment activities and found that interprofessional education and international placements had the biggest impact on our students. So for me, if we were wanting to ensure that students' values, beliefs, attitudes resonated with their codes of conduct, then we need to do more. Because my PhD was demonstrating that. So since then, I've always thought, well, I'm not going to do work in splendid isolation. I'm always going to do it with other people. So I've done things like worked with Carol Bartley, a fabulous OT, and we've done research looking at seating, evaluating seating in the community, nighttime positioning in care homes. Recently been in Uganda and set up nurse-led clinics of a multidisciplinary team to reduce type 2 diabetes.
Now, you've covered a lot there in that last few sentences, so I'm going to bring you back because I want to cover each one of those a bit more depth. I want to go back first of all to, you placing these multidisciplinary teams within care homes. The benefit that is not to the individual professional as well, because I find as OTs there's a lack of placement. There's lack of placements, and the second thing is that care homes are becoming such an important part. There's so many elderly people. We need multidisciplinary teams in there for the nighttime positioning, for the seating, for the feeding, for diabetes. We need so many specialisms in there. So do you hope in the future that might be something that the care homes will take on and that we'll work together to provide a more comprehensive treatment service for the patients?
Yeah, and we can actually see it already. In some of the care homes that were involved in the research project, they're now employing OTs and physiotherapists and sports rehab people. They've got gyms, one's got a swimming pool. So they've recognised the importance of the multi-professional team in the care of their residents, that, no, it's not just nursing. No. We need more of a greater team to have a better impact. We measured in the study the impact not just on the students, because we wanted to measure had they developed their knowledge, skills and personal development, because we wanted to change perceptions of what care home nursing and care home careers were.
Yeah, because sometimes they're seen as second best to hospitals. Which isn't really fair.
At
comment.
all. No. Then we wanted to measure the impact on the residents. So we interviewed the residents, and they said it gave them meaning and purpose, which to me then resonates with occupational therapy. And they all talked about giving back to the younger generation that they were helping train. These are their words, the next generation of nurses, physios, OTs, which is wonderful. And then we asked the staff, and the staff said, well, we've got loads of new evidence-based practices, new interventions, new equipment, new physical activities. So they said the benefit to them was huge, because they could transfer the knowledge that they'd gained from listening to the students, from watching them and the students presenting the work onto other residents in the home.
Very good. So the next thing that you mentioned there was your work with Carl Bartley and the work in seating, because obviously that is a passion of mine. And when I set up way back 20-something years ago, I went into care homes, and that was the one reason why I did what I continue to do, like develop seating, was because I could see people in care homes sitting so badly, and I knew as an OT the impact that was having. So, but I'm still educating. People still haven't got this message, especially in care homes, and maybe not all. I'm not saying all OTs have it either, but not nurses in particular. As a message we need to get out. So can you tell me about the work that you done with Carl and the importance of seating from a nursing perspective?
Yeah, so it all started with Carol Bartley, an occupational therapist. She was a lecturer at the University of Salford at the time. She came to see me, said, "Oh, I believe you got expertise in tissue viability. I've got this project to evaluate some chairs. What do you think?" So I'm a sunshine yellow person and green person on the inside program. So I'm like, oh, definitely excited. So we met with the company, devised a research proposal that we would recruit 12 participants in the community and they would evaluate their chairs. So we wanted to evaluate the pressure mapping, pressure redistributing properties, using pressure mapping, but then also look at other objective measures like the effect on the blood pressure, the pulse, the respiratory rate, because we would expect to see physiological changes. And then also other things like, does it help ease discomfort? Because we know that it's very hard for people to describe comfort, but they can describe pain and discomfort. So we measured discomfort and then generally interviewed them about their experiences, what they thought of the chair. So we did that with 12 people, and yes, it's a small study. It was a feasibility study, but actually it gave me great insight to how little I knew as a tissue viability nurse in seating and how important the role of the occupational therapist was. Because we've always known that when you sit, you put in your body weight through a smaller surface area, so you're increasing the risk of pressure ulcers, pressure injury to the ischial tuberosities, to your sacrum, to your hips, and having the right type of chair. So it provides that great posture. You know, working with physiotherapists when I worked in intensive care and with speech and language therapists to enable effective swallowing. And, you know, I learned lots with Carol about meaningful occupation in a chair. So I had known the link between poor sitting and poor seating, but I think this really exacerbated and expanded my knowledge. So when we'd presented those findings, the Society of Tissue Viability came forward and said, well, we'd like to revise our guidelines, our seating guidelines. They've not been revised for some time, and we know that both of you been doing research in this area. So would you please lead it? So the initial the second version of the guidelines, Carol and I led, and we decided that, again, I don't like sitting in splendid isolation, so we had a team of professionals from the society, some of the trustees, different professions, help us then develop the guidelines. So I'm a researcher, so the first thing we do is we ask a question, and then the next thing we do is do a review of the literature, because we want to see what evidence base is out there.
And there wasn't very much evidence.
No, not at all. Very much expert opinion. There was only a small amount of studies. There was one study of your chairs that was included, but lots of, what we'd say, expert opinion. But if that's the best evidence we've got at the time, we have to acknowledge that and include it, because we have to work from somewhere and give some guidance. But what I've seen since is obviously there's lots more research that's been conducted, not necessarily by nurses, more by what I see is like Pete Worsley down in Southampton, who was a physio by background and a biomedical scientist. So it tends to be biomedical scientists who are doing lots of the research on the pressure redistributing properties of seating, mainly cushions rather than the whole seating. And then obviously colleagues in Japan who are doing lots about shear and friction forces. So for me, I think that we've still got a long way to go.
One of the things that I would like to see, and how realistic is this in the near future, mandatory assessment for seating.
That would be fabulous, wouldn't it?
In hospital and care home. How do we go about doing that?
I suppose we need to develop the evidence base then, don't we?
Yeah, we're trying to do that as we go along,
And I think there's lots that we could do, maybe a PhD, a funded PhD, or a knowledge transfer partnerships, or, you know, if somebody with that passion to actually say, well, the current risk assessment tools, and then the choice of products, chairs should be part of that process. Because we know that when someone does a risk assessment score and a skin assessment in the NICE guidelines, it then suggests, choosing the right mattress, choosing a cushion. We need to say choosing the right chair because it's so important.
So that's where, we have similarities, because a lot of Seating Matters is about education and the handbook, and we talk about the 4 principles. Like, it's not just about the cushion, it's about the 4 principles of seating, or 4 principles of pressure management. So I like the fact that a lot of the research you do, we can actually implement it into daily work, because that's important. The research is really important, but it's only valuable if it's used. Isn't that right?
Absolutely. And one of my other roles is I work for the National Institute of Health and Care Research. I work at the Northwest Regional Research Delivery Network. And this is all about developing research capacity and capability. But we also recognise that we need to then, when we've conducted the research, mobilise that knowledge. Because if we don't do anything with it, it ends up being the end of the project. No one actually implements it into best practice. So there's lots of work being done on knowledge mobilisation and actually taking what we've found from research into practice and making it.
And I think as well as that, we did a KTP, like a knowledge transfer partnership with Ulster University, because I think it's important to work with the business, the manufacturer, so that we can adjust the product to meet the needs of the patient, and reflecting on the research that you've done and the outcomes that you're looking for, that we've worked together to improve the outcomes for the patient. I think that's important as well. So you also want to bring you back, you mentioned there about your voluntary work that you do. Tell me about that.
Yeah, so I was asked to become a trustee for a charity called Knowledge for Change. And Knowledge for Change is situated in Uganda and Tanzania and Zanzibar, and this charity offers student placements overseas and volunteering placements, but also at the same time uses that money to actually implement evidence-based practice in those countries.
And this is in healthcare?
It is, yes.
What type of tissue? Viability?
Yeah, so I was first invited by Louise Ackers, who's the chairwoman of the charity, to do some work in tissue viability. So they'd found that lots of women were dying after a caesarean section because of infection. And she recognised, everybody talked about this horrific smell on the maternity ward. And these women had suppurating surgical section wounds and they were dying from sepsis. So she said, well, what can we do about it? So we developed with the nursing staff, because this is all about empowering the nurses, the midwives, the allied health professions in the country to become the next leaders and make change happen. So we did lots of training, and we actually had virtual wound care clinics. So the students on the wound care course in Salford were live streamed into Uganda, and we would have multidisciplinary team meetings about cases. And then we'd talk about what best practice would be. So we could help them develop their knowledge and skills of, again, interprofessional working and improving wound care. And what happened is, with implementation of wound care education, they don't have much money. There's very little resources. So the dressings they use are gauze. And we recognised that they were mixing honey with gauze, but it was honey bought from the farmer's market that the patients bought themselves. So the pharmacists bought their own honey, made it sterilised and made sure it could be mixed with the gauze. And by using honey and gauze, actually, mortality rates went to 0. So women stopped dying from sepsis, from wound infections within the year.
It sounds like a very cost-effective way, and yet we're spending billions of pounds here for... Do you know, that sounds like a very cost-effective way to reduce mortality.
Yeah, so there's lots of frugal innovations that we can actually learn from what we call low to medium income countries. I mean, there's a really interesting study. I know this is not about chairs, but it's about if somebody has a hernia and they want to repair that and put in usually in this country, in the United Kingdom, the surgeons would put a Teflon graft in.
Yeah.
Well, they've been using malaria nets in LMIC, low to middle income countries, and the evidence base is clear. They're really cost effective and very frugal. And the surgeons there are saying, why can't we use them in the United Kingdom?
Frugal innovations. I saw that there on your one of your papers. Tell me a bit more. Have you done much work on frugal innovations?
Yeah. So the next project from the wound care project was then we wanted to look at, well, there was a call from the Burdett Trust saying that they wanted some research being conducted that was nurse-led in low to middle income countries, were having a collaboration with a UK university or a hospital. So we applied for some monies and we got, I think it was about £58,000, and we actually set up a nurse-led type 2 diabetes education programme, because obviously the non-communicable diseases such as type 2 diabetes are on the significant rise globally, and more increasingly in Africa. So we wanted to put in education because we knew it was low cost. If you educate people and empower them and give them the knowledge to understand that their diet and their lifestyle affects them developing type 2 diabetes, we can make a difference. So we did. We set up a nurse-led team. So patients were recruited from the outpatients department. So every Tuesday and Thursday, 350 people will just turn up to have their appointment. There's no time allocation. They just sit and wait. And we were like, well, we can recruit people from those two clinics. So we ended up recruiting 35 people who undertook this diabetes education programme. And within 12 weeks, most of them had gone into remission. And it was amazing, that some were not just statistically significant, but also clinically significant, that the shift in their diabetes, the HbA1c, had gone from like 12 and 10 down to 4.
And why are we not doing that here?
So I'm meeting with people in Wigan at the moment, the public health team. We've had conversations over this last year to actually look at transferring that frugal innovation from Uganda into Wigan, because we noticed, because I'm part of Greater Manchester, 22,000 people were diagnosed with type 2 diabetes in Wigan last year. So for us, it's an epidemic.
And a large percentage then possibly could manage it with education.
Yeah, and diet alone. So we were thinking about what we've learned from Uganda, from following people's journey. We do a lot of, Louise is really good, working in public health and in law. The first thing we do is characterise people's journeys, because for us to understand how we're going to have a better impact, we need to know what normal journeys look like and how did people end up with. So I think there's lots to learn in tissue viability and pressure ulcers. How did people end up with a pressure ulcer? So I know we've got harm-free care panels, but we don't really characterise the journey. We're looking more at the faults that might have happened, or any risk assessments that haven't been undertaken, mattresses that haven't been delivered. For me, it's not about blame and fault. It's about, well, what's that journey been like, and where could we have interjected and been more efficient?
It's sort of like our process here. We don't blame the person, we blame the process. You look at the process and see how you can improve the process.
Definitely. And characterising journeys of patients, we can, or people, because not everybody, I know we've all got an NHS number, it doesn't mean we're always a patient. How we can then improve, well, where could we have interjected? Where could we have made a difference? And the diabetes education in Uganda, we were educating people with literacy of primary school level. So we made it very simplistic and almost a course that anybody could really deliver.
And you got the results.
Yeah, and they became champions. So they then went on and became ambassadors and told their friends, you can't eat that, you must eat this, and do more exercise.
Yeah.
So
good. So, Melanie, you're associate professor at Salford University, or the University of Salford, is that what we call it? What is your main passion with regard to your work? Like, is there one thing that you really want to achieve in your job there?
Do you know, I tend to bumble along into different things. But I think now I've got into a really wonderful group of nurses and other professionals and researchers that's all in social care, because I think it's been a Cinderella service for so long. And there's incredible work being conducted by OTs, nurses and physios working in that sector that's it's unseen of and unheard of. And for me, it's about creating voice and parity of esteem now for those working in the social care setting, because most of our research is in healthcare.
Yes.
And yet, if you think, like you said about care homes, there's no more beds in care homes now than there is in the NHS. So we need to do something about that. We need to raise the esteem of those working in the sector, because the embedded perceptions are really awful and poor. And it's so wrong when you actually go and work with people who are providing such services. And then also we need to raise the amount of evidence base and research being conducted there to demonstrate that with very little money, with very little staff, with unregistered staff, they're doing amazing things. So we need to demonstrate that.
So that sounds like a passion. And you've got awarded for that. You've been recognised. You got the Queen's Gold Award. Am I saying that right? Tell me about the award that you've received a few awards.
Oh, thank you.
So tell me about the awards.
Yeah, so I've got great colleagues who I work with.
You've been nominated, obviously, so people are recognising the work that you're doing.
Yeah.
So what awards have you got? Tell me about them.
So the first one was a team award. So it was the Chief Nurse for Social Care's team award for the IPE project. And then...
That's IP is interprofessional
education, yeah. And then from that, my colleagues felt I should have had an award on my own for leading all of that work. So they then submitted an application that I received then the Gold Award.
Very good.
And then the end of last year, I then was given the title of Queen's Nurse. So this is given to nurses who go above and beyond, giving servitude really to the community, and mine was for services to social care. So
very good.
yeah.
Well, when I asked about passion, I think it's very obvious that that's where it is. It's within that social care, and it's an area that definitely deserves the attention. So well done, and keep up the good work.
Thank you.
So, Melanie, we work here. We have a whole clinical team, and we do a lot of research in clinical trials as well. And when they knew you were coming on for a podcast, we were very excited. And as I say, I'm very honoured to have you here. So we asked our clinical team out there who are working day and daily with our patients, had they any questions for you? So I'm going to ask you a few questions that come from our team. So Norma is our head of clinical operations. And I'm just going to read out her question and see what your response is. She said, in her experience, not all district nursing and tissue viability teams consistently link the delivery of 24-hour posture care with pressure injury incidents. And from your perspective, what does the current evidence tell us about this relationship, and where do you see the main gaps are in clinical understanding?
Wow, that's a big question.
That's a very long question, isn't it?
Shall we break it down?
So really, Norma is very passionate about 24-hour care. And what you're saying is that not all tissue viability nurses and nursing teams see the link between 24-hour posture and skin breakdown.
Yeah, so I think the approach is multifaceted. I think we need to tackle it from many different points. I think there's work being done with undergraduate education. We know if you look on the European Wound Management Association and what used to be the National Wound Care Programme, not many universities have a dedicated wound and pressure ulcer kind of module or week or activities. And so I think we need to embed within undergraduate programmes. And UMA have been really good because they develop the different competencies and proficiencies and learning outcomes at each level of a programme. and post-qualifying, postgraduate kind of level. So I think there's mapping of that would really help for universities. So I think it's that. So and I don't just think that it should be just nursing. It should be physio, OT, podiatry, even though they're from the hip down. I think we need to think more widely across our professions. I also then think there's work to be done with tissue viabilities and OTs perhaps coming together and doing some joint education. Industry are always helping, like you do lots of education, and I think that should continue. And I'll give an example. I'd recognise, with doing the work with Carol, writing the seating guidelines, we developed a week at Salford called Getting Wound Care Right Week. We actually wrote about it with some students. And this week is all about the skin and looking at, the anatomy and physiology, wound healing, and then all of the different kinds of chronic wounds or acute wounds students can see. And the end of the week, we had an exhibition where we'd invite companies in, and a seating company would always come in and talk about seating, because we wanted the students to have that level of understanding and awareness before they became registrants. So for me, we need something like that across all programmes.
I think it's a matter of just keeping working, because with the Queen's University here in Belfast, we have, over the last 2 years, we have done a seminar on the importance of seating and pressure ulcer prevention. We have done that for their nurses, their undergraduate nurses. And so it's something that, we need to keep working on. Do you still do that week with Salford, or was that a one-off thing?
We'd ran it for quite a few years, but then there was recent changes. So we don't do as much, and we don't do that exhibition, but we're writing a new curricula now. So myself and other members of staff with an interest in tissue viability, we've all agreed that we would like that week back. We want to claim it back.
Don't forget about seating when you're doing
not at all. So important.
Because it is so important. It is. We have the evidence there to show that. So the other thing that Declan has asked me to, there's this campaign of get up, get dressed, but how important is it from your point of view, getting the person up and getting them dressed if they don't have the right seat beside the bed? How important is it, to have a proper seat as opposed to just your bog standard hospital seat?
Yeah, and it goes back to that thing that the patient's better now, they can sit out for a bit. That's very simplistic in its terms in itself, and even get up, get dressed is simplistic, isn't it? We can understand why. We know that if somebody's motivated and we can help change the behaviours, that actually that sense, the release of happy hormones when you start to see yourself progressing and getting better is a real enabler to do more. But you're quite right. The seat next to the bed is equally as important as the mattress on the bed itself. And I think that we need to make more of that connection of it's not just about putting a cushion on a chair. It's about choosing the right chair with the right cushion. Because I always say that we don't reposition a patient, whether they're in a chair or a bed, just to prevent pressure ulcers. We do it, first of all, because for social contact. We're humans. The importance of touch, therapeutic touch, it can't be overrated. We then also do it to improve posture. We do it to improve digestion. We do it to prevent deep vein thrombosis, pulmonary emboli. We also do it because it's a form of communication. And whilst you're caring for somebody, repositioning them, whether it's in a chair or in the bed, you're actually engaging in that wonderful relation, nurse-patient, OT-patient relationship. So I think that chair is equally as important as also things like nighttime positioning equipment and the cushions that we use to position somebody. So I think that we should never sit in splendid isolation. I'll go back to those two words, that we should be a collaboration when it comes to pressure ulcer prevention.
Very good. We often say, it was one of my sons, Jonathan, came up with this, that the diagnosis doesn't change from the bed to the chair. You know, if you have someone with a stroke or hemiplegia in bed on a specialised mattress, when you put them out to sit, they're still the same person. They've still got the same issues. So the chair should be equally as supportive as the bed and mattress. But people don't. We like to talk about it. It's not just a chair. It's a therapeutic device. It's going to really help that person heal and mobilise. So I think the message is it's not just a chair. It's more than that.
Yeah,
That's
definitely.
what our message would be. Tracy has asked, with increasing workloads and reduced establishment resources, what are the non-negotiables when it comes to tissue viability care that clinicians should always prioritise?
Non-negotiables for me, I think first of all it's a good assessment, because you can't if you negotiate on an assessment, and I know people say it's an ongoing process, but you need to do a good assessment. So you need to know about your patient's history. You need to know about the current state of the skin and the condition, and what equipment currently do they have available, because then you can make a better informed clinical decision. And it's then recognising where you lack knowledge. And it's okay to lack knowledge, but it's important then to get help from other people. So for me, as somebody with a tissue viability background, it's using all of those colleagues in your armour to call upon and say, well, actually, this person doesn't just need a mattress on a bed frame. They need the occupational therapist. They need the physiotherapist for better positioning. We need the speech and language therapist. So for me, the good assessment, and then the good assessment leads to better decision making.
So the non-negotiable is, like, if there's limited resources, you still have to do a good assessment, do the patient journey, find out why they are where they are, and try to move forward from there. And if you don't have the skills, seek them out.
Definitely. And also the resources, because there are ways and means. You know, when you seek help from other people, they will help you achieve your goal for your patient, because they'll know of I'm not saying shortcuts, but they are shortcuts, but they're ways of accessing. We did a talk recently with some students that we informed of some charities locally, because staff were saying can't get a hold of equipment, and we said, well, are you aware of some of these charities who were quite happy to help buy this equipment for you? And they were like, no, we didn't know that. So we were trying to help in these resource-strapped times.
That's what we try to do as well when we do an assessment, look at the options available to them. I do think clinicians need to really, as you said, do a really good assessment, and then go and, fight for their patient or their corner and say, they really, really need this for these are the reasons, and I have the evidence, and I know what I'm doing is right. So I think it's a lot on us as well as the clinician, I think
we need courage, don't we? And I always talk to students about having courage to put your head above the parapet and say, actually, no, I'm not going to put up with this. No. It's not acceptable. This is what the best practice guidance says. This is what the NICE guidance says. This is my PIN number. I mean, when I was a staff nurse, on many occasions, I always had the NMC Code of Conduct in the hard copy. Yeah. And I used to pull it out and say, where does it say in there that I can't do this? Because it's my PIN number and I'm not losing it.
That's right. I really agree with that. I really think if we really be determined about, we know what we're doing, we know what is right, we can make a difference. And I think people maybe take the easy way, or they get overwhelmed.
Yes.
I think that's the words. Maybe they care enough, but they just get overwhelmed, by being told so often, no, you can't have it, and then they just accept that.
Yeah.
One more question from Jonathan. How can we get more TVNs to think of the whole seating and not just the cushion? That's the thing we find. They say, we've done a seating assessment. How can we get past that it's not just about the cushion? How can we better challenge the bed rest as an answer when speaking to TVNs? Because sometimes the TVNs would say, they're on bed rest because they've got a pressure injury. And we say, no, you need to get them up. And, we have evidence that if you get them out of bed and position and do the 4 principles and all that you can help to actually heal. So how do we get around that? Maybe you've answered that question already, but just to recap.
Yeah, I think we worry about litigation a lot, don't we? So we worry that we're going to be assessed that we've had a breach of duty and we've been negligent in our actions or omissions. And I think that it doesn't just rest on one person.
No.
So I've worked with lots of teams where we've had a team decision. So we've decided as a team,
Yes.
this is reasonable. And actually, if you were to put somebody into a chair for a short period of time, actually getting them out, even though they have skin damage, even though it's a short period of time and it exhausts them, and when they get back into bed, they actually sleep better because we've sat them up, and the actual release of the good, happy hormones has been so good to the skin because it flushes the skin. There's more oxygen. It takes away toxins and carbon dioxide. They feel better. They tell the family, I've been sat out today. And the family go, oh, this is a milestone. You've been sat out. So I think that we need to, one, make decisions as a team. And what is the outweigh the benefits and talk to the person and say, well, these are the risks we're worried about, but let's do this together. Let's have an agreed risk. You know, we do lots of things nowadays that we wouldn't have done years ago. Like I think about risky feeding. Yeah. People are given choice now, even though they know they might aspirate fluids or food, that they're given choices to do that. So I think that we can make more reasonable risks in a better informed way as a team and with the person. And then I think joint visits. I think OTs and nurses and physios having visits together. But I know that's everyone says about being time limited. But I think the more we do them, actually we save time. We save time in the future. And then some joint education, because I think that if we had, learning together, we learn from, with and about each other, going back to like IP care homes, IP, diabetes, self-management programs, actually we can make a better impact on the person. And also then if somebody isn't there, they're off sick, we're all have got those knowledge, skills and attributes, so we can cover each other.
I think you've hit the nail on the head, really. It's about teamwork, back to your collaboration, working together.
I think I've been very fortunate in my career that I've always worked in interprofessional teams. From the first ward when I qualified was an endocrinology and older people, a gerontology ward, and Mike Cheshire was the consultant at the time. And in the morning, we were told as nurses, no, you're not doing the washes. The OTs are going to come in because we have this thing in nursing, we do a lot to people. We want to take over. Whereas I've learned so much from my OT colleagues of, no, this is about rehabilitation, reablement, meaning and purpose. So the OTs came in and did the washes and the bathing and the personal hygiene, because it was about helping that person develop their independence and not decondition. So, I mean, there's lots of work being done, and there's some amazing frailty nurses out there who are helping develop knowledge. But I think we've still got a long way to go.
Well, I think too, like OTs are the same. So tissue viability nurse, historically, somebody's got a pressure and you keep them on bed rest. So we're moving away from that. But everybody doesn't think like that now, but we still have that core of people that think that. And like the same in OT, I had a guy here who we were discussing this with, and he says, look, OTs, someone with dementia doesn't get a stair lift. Well, what he said, well, then what happens? What's the alternative? You don't give them a stair lift, so they can't get up their stairs, so they can't get to the toilet. So what do? Do you go to the care home? Like, what is the outcome of making that one decision? And you can't just say someone with dementia doesn't get a stair lift. You have to do an individual assessment and put things in place so that person can use a stair lift. But I know when I was in the community 25 years ago, somebody with dementia, no stair lift. That was sort of a rule. So it's the same idea. Somebody with a pressure injury, they stay in bed. So we just need to work through and just change and learn to work with, as you say, collaborate with others. So, I think good answers to the questions, Melanie. Thank you so much. So we're going to wrap up, but before we do, tell us a little bit, first of all, about the person, Melanie, what you do in your spare time. Tell us a little bit about yourself and what your hobbies are, or where you like to travel, or tell us a little bit about you.
So I'm married. My husband's a mental health nurse. I have 2 children, 21 and 26. I love travelling. I love walking. I absolutely love walking. I love My family call it, I love murder, death, kill programs. What they actually mean is I love murder mysteries.
All right.
They call it murder, death, kill. But I like mysteries that you need to solve. I love reading. I love lots of reading about self-development, about improving myself.
What sort of books would you have read in that?
Yeah, so I'm currently reading Viktor Frankl's book. So
Man's Search for Meaning.
Just because as well, supervising students for PhDs, we always talk about your philosophical assumptions and where these come from and what's formed those thoughts and decisions. So I always like to read different books. They're the kind of things. And I love, you might be able to say, I like eating, I like food, I like going to different restaurants.
And you were in Japan recently?
Yeah, I was really fortunate to go to Japan. I was actually presenting with a physiotherapy colleague of mine on the impact of physiotherapy in care homes.
Very good.
And my parents had died, and in the sale of the house, myself and my siblings all had a small amount of money. So I said to my family that, well, we're going to use Grandma and Granddad's money and go to Japan.
Very good.
So we had a wonderful family holiday. And at Christmas, my son bought me a picture. I'd asked for a picture of us at the four of us at the 1,000 Tory Gates.
Oh, lovely.
So he'd done that. But then he did this extra special thing, which was a book of all our...
Off the
It's
trip.
making me emotional.
Oh, very
Of
good.
all our pictures from
On the holiday.
Yeah.
Oh, very nice. Picture book. That was lovely.
Yeah. So all
Very
those
thoughtful.
special moments. Yeah. Yeah.
Very good. That was very nice.
It was lovely.
Yeah. Just going back to that book, Man's Search for Meaning, I do volunteer work at a prison, and there's a young guy in the prison, and he was there by default. He shouldn't ever have been in prison, and that's the sort of people you meet. He just did the wrong thing at the wrong time, and he was really beating himself up, and he felt that the prison was really getting to him. So I gave him that book, and I says, they can do anything to you, but they can't get inside your mind. So he found that he's I was going to say discharged. He's released now, but that book you're reading was very beneficial to him. So it's a good book. So we're going to finish off with, we always asked most of our contributors to the podcast to tell us one story that meant something to you in the course of your work, something that you felt that you really had an impact on a patient or a family member. Is there anything comes to mind?
Yeah, and I was mentioning it to Dervla last night. So as a tissue viability nurse, back in, I think it was about 2001, I was asked to go to see a young gentleman he'd come from India with his family, and initially they thought he'd got tuberculosis of the skin. Right. But actually when he'd had all the tests, because he came to the infectious diseases unit, he'd been found to have non-Hodgkin's lymphoma of the skin, and it was really advanced. And he'd come with his very caring father and his very caring brother, and they made the decision, really almost out with of him, to stay and have lots of treatment. And it sat with me very uncomfortably. Every day that I used to go and visit, I'd think, but this is not what he wants. I can see it's not what he wants. And you could see in his eyes, he'd look at me, and talking to the other nurses who were caring for him, everybody, because we were all new mothers, we all kept saying, this is not right. His mum's at home and his other siblings are at home.
What age was this person?
He was 19. So we knew his prognosis was poor. So in one of the meetings, I grabbed his hand and said, "What do you want?" And he said, "I want to go home and die in my mum's arms." Oh. So I'm sorry, I will get upset. So I took the courage to speak to his father and his brother and said, "I'm really sorry, but I'm going to have to tell you that that's not what your son wants. Your son wants to go home, and I'm going to make it happen." So I have to say thank you to British Airways. It's a long time, it's quite some time, 23 years, isn't it? 24 years. So they really helped, and obviously the ambulance transfer system, and the dad and the brother agreed, and I got a letter from his dad saying thank you that he actually got home, and he actually died a few days later in his mum's arms. So
because
for
the
me,
alternative was he was just going to die here.
In-
But they were just clinging on to the last bit of hope, weren't they?
yeah,
And did they come here for treatment?
they did, and you
Yeah.
could see obviously
They were clinging on.
Oh, absolutely, loved him. But I was sorting out my office. I recently had an office move, and that letter. I always keep letters that have been really meaningful, and that letter dropped out of this envelope that I keep. And, you know, it reminded me, and I'd regale this story to students and say that, you know, sometimes we have to ask and have the difficult conversation and have courage. Because if we don't, then I couldn't have lived with myself knowing that he died in this in Manchester. I knew he wanted to go home, and we wanted to make that happen. And, you know, when you look back of anything that I've achieved, it doesn't matter about my titles or my qualifications. I got that young man home.
Oh,
So sorry.
you're going to have me in tears now. I know that is such a lovely story, and it just shows you also the sort of person you are. You know, it's not about, as you say, the titles and everything. But for anybody listening to the podcast or watching the podcast, you should really look up Melanie, because I haven't touched on half one wee bit of the accomplishments that you have achieved and all the work that you've done and all the papers you've written. You know, I haven't even touched on, I've only scraped the surface. So I think people should really have a look at what Melanie's doing, you're doing such a great job. And just finish off, you're coming to Dublin. You're going to be in Trinity. Just finish off with that.
Oh, thank you. Yes. I've had the great honour of being offered the role of visiting professor at Trinity College Dublin. So I'll take that post up in October this year.
And you're going to have your first lecture in October.
Yeah.
Your inaugural. Well, it's a pleasure it's you saying it's an honour for you, but definitely a big addition for them to have you on board with them. So they will benefit greatly from all your knowledge and all your passion. And thank you so much for coming on. As I say, I've only scratched the surface, but I'm sure we'll stay in touch, Melanie, over the next few years, and maybe we'll do some collaboration together in the future.
Oh, that'd be fabulous. Thank you for asking me, honestly. It's been a real pleasure.
Thank you, Melanie. Thank you.
Thanks.